Welcome. My name is Alan Keating, and I've been a PA for right about 30 years. Um, about a third of that has been emergency medicine, a little over 10, 11 years of emergency medicine, split with orthopedics and pain management, about a third each throughout my 3 decades as a physician assistant. I have the privilege of being able to speak to you guys, to record this lecture for you, and I hope you enjoy the lecture and learn a little bit as you go along the way in the world of acute abdominal pain when a little rumble becomes a major problem. Let's go ahead and um, read the objectives. Okay, so the training session today will enable you, the clinician, to recall the most prevalent and critical abdominal pain disorders and illnesses. So this is a combination of both things that are very common and things that are critical, and sometimes those that are both at the same time. You'll be able to utilize key history questions and multiple clinical pearls for assessing emergent abdominal cases. Employ the current emergency treatment protocols for acute abdominal pain patient. Remember the vital physiological differences between pediatric and adult patients. A few things that are different about them compared to us and what you should look for when treating a child. We'll have a short little sidetrack into the pediatric world. And then finally, you'll be able to learn from two cases I'll present at the end, and it'll kind of reinforce the lecture material. So review and assessment. Where do we come in? Okay, where do we as clinicians come in, and what do we do when they come to us? Let's do a quick review of abdominal pain and the abdomen itself. So the gastrointestinal system makes up the majority of that which is in the abdominal cavity. There are definitely other structures that do other things, urinary tract, reproductive tract, etc. But most of the disorders come from the gastric, GI tract and problems with the GI tract. GI tract is responsible for giving us the good stuff and removing that which we don't need, and with the good, out with the unneeded. And the problems come predominantly with mobility and malabsorption, and then at times trauma. But the first two are really the main ones that create difficulties, and then also infection that comes as a secondary result. Little side note, 2022 abdominal pain got to be number one reason anybody went to the emergency room in the United States for all ages. It was number one even in the middle of the COVID years. The disorders of how they present, signs and symptoms, depends on whether it's an upper GI or lower GI presentation. You're going to have the nausea, vomiting, dyspepsia with the upper GI issues. And of course, you're going to get your gas, your bloating, your diarrhea, frank red rectal bleeding, etc., as well as abdominal pain in the upper and the lower quadrants. And we're going to tease out, and I've set the lecture up based on the 4 quadrants of the abdomen. Now, the term acute abdomen is defined as the signs and symptoms of severe enough to require surgical intervention. So this is, if you believe you have an acute abdomen, you need to make sure you're calling a surgeon to consult on the case. Acute abdominal pain equals intra-abdominal pathology. We don't really perceive our GI system working and all the different systems working until there's a problem. So if we feel that we're having pain there, there's a problem there. The person tells you they're having pain there. There is an acute intra-abdominal problem, probably going to need surgery. One of the tricky parts with abdominal pain presentation is it doesn't always come to us in the classic presentation. In the classic appendicitis presentation, as we know, periumbilical pain radiating over a couple of days down to the right lower quadrant. Also, acute abdominal pain compared to chronic pain is more visceral. It's faster onset. It's going to progress faster. They're going to get to you probably within sometimes a couple hours, and then sometimes a couple of days. Rarely is it multiple months, although you'll see something about that much later in the lecture here regarding month-long pain. Also, the history is vital. History in the general location will tease out a vast majority and a limited vast majority of your differential when you're talking to your patient. Please take the time to find out when it started, what's it feel like, do you have a fever, do you not, nausea, vomiting, diarrhea, what's the emesis look like, what does the diarrhea look like. Tease out all the fine points of the history so that can, again, dial you into your definitive diagnosis when you get to that point. What you made your diagnosis, treatment depends on obviously what the presenting problem is, what is the confirmed diagnosis. When you're in your office, you're in your outpatient setting, the internal medicine, family practice, pediatric setting, what can you do for this acute abdomen patient prior to hospital admission through the emergency room most often? Well, you can get back to the basis and do the history and physical. In fact, you should almost be ready, should be able to give us a high likelihood diagnosis based on history and physical, confirmed with whatever labs you have at your disposal to do in your office, and do any lab that you have. Please do that. And you're going to help the speed of the treatment and give us much more information rather than we have to start all over when the person gets to the emergency room. Labs, do all the labs, but if you have the ability to do an abdominal series, go ahead and do it. You can sometimes see small bowel obstructions, you can see foreign bodies, you can see whether there's stool present, etc. You may not get all the answers, but you can certainly rule in, rule out certain things with a plain film x-ray. The additional outpatient treatment protocol, what can you do for them beyond the labs, studies, and exam? Tell them, do not eat or drink, do not eat or drink. Tell the family members, please do not stop. If they're going to take them to the emergency department, they're not going to go by ambulance. Please do not stop by the fast food restaurant and get any food. No food at all whatsoever, because if it's a surgical situation, which more than likely it is, please don't. Start fluids, antiemetics if need be, etc. Whatever you have the ability to do in your office, please do so. Now they get to us, what we're going to do. Of course, we're going to do everything. We're going to do the EKG to make sure that this epigastric pain is not actually an MI, which I've had happen to me before. A gentleman said, hey, just give me that green stuff, and they were actually having an MI. But the most definitive study that we do in the emergency department in a hospital setting is a CT of the abdomen and pelvis with and without contrast. That's the gold standard imaging. That is what we rely on to confirm, not give us our diagnosis, but to confirm our diagnosis. We're going to do CBC, Chem 20, urinalysis. We'll do a urine HCG, then follow it with a serum HCG. We're going to do all the blood work that we have the ability to do, which is essentially everything. Our treatment, number one treatment, is don't eat or drink. Just like you in the office setting, don't eat or drink. Tell the family members that they're hungry, please step out of the room. Don't torture the poor family member who has intractable emesis with you eating in front of them. That's just kind of not kind, okay, uncool. And it also tempts the patient, quite frankly, to eat. So if they're kind of feeling better, we don't want to do that because that can make surgeons very unhappy when the patient's eaten. We provide pain medicine, fluids, antiemetics, continuous antiemetics, and then obviously confirm the diagnosis, get the surgeon on the phone, and get the surgical consultation. Now let's go ahead and walk through starting in the right upper quadrant with acute hepatitis. Now these folks can come to your office, they can come to the urgent care setting, they can come to the emergency department. This is defined as a diffuse liver inflammation caused by specific hepatotrophic viruses. Which viruses? Well, Hep A and E are fecal oral, and then Hep B and C are going to be blood or parental. Now, how do you remember which is which? Well, just remember that cable channel A&E, and that gives you fecal oral. We know kind of almost all of us 100 across the board that Hep A is foodborne, get it through contaminated foods that we eat, usually outside of our house. And B is associated, of course, with HIV, which we know is bloodborne, and B goes with C. So just going to pair those, and you'll be sure to get that board question. Unfortunately, severe hepatitis can lead to fulminant hepatitis and potential liver failure as well. It's going to be a viral syndrome, but the trick of, kind of thing that sets you apart, I mean, viral syndromes can present very similar, but in this case, it's going to be a viral syndrome without necessarily any kind of cough. and they're going to have abdominal pain. They're going to have it predominantly in the right upper quadrant, sometimes in the left upper quadrant. They're going to have total lack of appetite, which is anorexia, absolute no desire for food, and jaundice. So you don't get any jaundice with respiratory issues unless it's a latter stage issue. But you're going to get that jaundice. The person's going to be obviously jaundice. They're going to have ecteric sclera, and you're going to be like, okay, there is something definitely wrong with this person's liver. Labs, AST, ALT, and bilirubin are your three main labs to confirm the presence of the hepatitis along with your exam. Not necessarily needing to do a study initially with hepatitis. Supportive measures, admission for cases of jaundice, significant jaundice. Some people have a low-grade hepatitis and they don't actually have the jaundice, so we can consider discharge home, especially with symptoms are mild. At times, it can lead to surgery, but it's not very often. And the really good thing about a hepatitis is it usually self-resolves, and then later on the patient develops the antibodies, and they're protected from future exposure. Acute cholecystitis. I'm going to go in depth here on acute cholecystitis versus acute cholangitis. Now, interesting thing here, acute cholecystitis, of course, is problems with the gallbladder due to gallstones, 95% of the time. The odd thing is that gallstones that are formed in the gallbladder are secondary stones. Why? Who knows? I don't know how and why they decided to make primary gallstones or primary gallstones be those that are formed in the common bile duct or the bile ducts, whether it's the hepatic ducts or the common bile duct, more often not common bile duct, and they're brown in pigment, where the secondary gallstones are the ones in the gallbladder. Go figure. They tend to be more often than not formed by cholesterol. About 25% of the time, they actually have some calcium in them. You can see them in plain from X-ray. Now, let's say we do a cholecystectomy. Now we fall into the realm of residual or recurrent gallstones. And the residual stones are those that occur within 3 years after cholecystectomy. Recurrent stones are the ones after 3 years. I don't know how you pair that in your mind in case you get some nitty-gritty board question about a patient presenting before or after, presenting after cholecystectomy, but with before or after 3 years. And is it residual versus recurrent? Okay. Pathophysiology, gallbladder has inflammation and due to a gallstone, and then it leads to essentially infection in the cystic duct. 95% of patients with acute cholecystitis have gallstones present, and unfortunately 10% of the time it can lead to a perforation. Let's go through the pathology using a lovely picture. I actually got this picture. It is a stock picture. I have, you see there in the bottom, I've given credit to the person who created this picture, and then I was able to add some things to it. So I added those lovely little gallstones hanging out down there in the gallbladder. When they're down there all by themselves causing no problems, it is called cholelithiasis. The problem comes when one of the stones pops out of the gallstone and gets stuck in the cystic duct. When that happens, you get the inflammation, and then you have acute cholecystitis. Okay, stones alone, not a problem. Stones get stuck, big problem. So that leads to, okay, let's follow the cascade of the inflammation. Gallstone impaction leads to cystic duct obstruction, leading to bile stasis, leading to release of inflammatory enzymes. Okay, so things get inflamed because they get backed up. Next, though, this inflames and damages the mucosal lining, the intermucosal lining of not only the cystic duct, but also the gallbladder. This triggers more fluid secretion, which gives you bladder distension. Okay, now we got gallbladder distension, followed by release of additional inflammatory mediators, because why? The gallbladder is distended. Great. Worsening mucosal damage occurs, followed by ischemia of the lumen, inflammation, additional inflammation. So this is just a over and over inflammation on inflammation on inflammation and inflammation, leading to finally bacterial infection because the natural barriers that prevent any kind of bacterial infection are broken down. And then that leads to gallbladder wall necrosis. Now we're in a situation of cellular wall death, and then finally perforation in the worst case scenario. And we definitely 100% want to catch this person sometime up here or even earlier. when they're beginning to have that presentation, the early inflammation, so we don't end up down here at the bottom with perforation and a very serious, potentially life-threatening situation. Cholecystitis symptoms are severe, constant, persistent right upper quadrant pain with fever, nausea, vomiting. It's possibly preceded by a meal more often than not, but not always. You can always have atypical presentations and symptoms as well. Pathognomonic finding, Murphy sign, Murphy sign, Murphy sign. We should all know Murphy sign. Right upper quadrant tinnitus with a deep inspiration with your hand with a deep, slow palpation into the right upper quadrant. Remembering to get underneath the liver border doing it. However, when you do your test, whether it's a CT, whether it's an ultrasound, or whether it's a HIDA scan, and the radiologist interprets that study as having acute cholecystitis present, you better call the surgeon. If you don't, you'll eventually get a piece of paper from somebody legally saying, hey, join us in court because you made a mistake. Always call the surgeon. Acute abdomen is a surgical situation. You might have elevation of the white cell count. Usually it's common, but doesn't have to be. You might have elevation LFTs, but may not. You may just simply have a large stone and acute presentation. Treatment is the antibiotic stabilization and cholecystectomy. When there's a rupture, we're going to do emergent surgery on the patient. Usually, if we can cool down the gallbladder for a couple of days, it's best to do it when it's not so hot so it doesn't, quite frankly, fall apart during surgery. Outpatient basis, if the person has more biliary colic, so a stone gets stuck, couple hours of pain, then it gets better. Stone gets stuck, couple hours of pain, kind of repetitive pattern, and you've confirmed the presence of stones, you can do elective outpatient cholecystectomy. Now let's go to cholangitis, and how is cholangitis different than cholecystectomy? Let's start with stones again. The primary gallstones. The primary gallstones present in the common bile duct. That is choledocolithiasis, the doco standing for duct. So common duct stone, primary duct stone, choledocolithiasis. Gallstones in the bile ducts, predominantly the common bile duct, but you can have it higher up in the hepatic ducts. They form, and 85% of the time, these stones came from the gallbladder. Okay, so you can get cholangitis after cholecystectomy, but more often it's when the gallbladder is still there. When it blocks the duct, low, not at the cystic duct, but further out, you can get backflow up into the hepatic tree, hepatic ductic tree, and then you end up with, right there, obstructive jaundice, and there's your key word for your board question. So obstructive jaundice is associated with acute cholangitis. Then it leads to a cascade of difficulties, which ultimately leads to cholangitis. You see there, acute cholangitis has multiple names. I put them all down there. Acute ascending cholangitis. This is a bile duct infection secondary to the obstruction and the obstructive jaundice, and then the bacteria, because the flow changes flow, so it's always downstream. Well, the stream changes and bacteria is able to get up and ascend into the common bile duct and create a very serious infection, a very serious situation. Morbidity, who is the bug that is most likely sorry about that. Who is the bug that more than likely is causing the problem? Of course, it's our old friend E. coli. We have it in our GI system all our lives. E. coli is our friend until E. coli is not our friend. And in this case, not going to be our friend. But E. coli is the leader of the pack of the gram negatives. Then you also have gram positives, but more often than not, you're going to find that it's the gram negatives that are the offending bacteria present in this situation. Let's go ahead. We got the common bile duct and we got ourselves a gallstone sitting in there. If there's no problem, you may just have choledocolithiasis, but potentially sometimes you can have backflow up there to the right and left hepatic duct and common hepatic duct. But when it gets obstructed, we're going to get obstructive jaundice. There's that key word again. When it is totally obstructed and totally locked down, you start getting inflammation of the common bile duct and bacteria. Ready? There you go. Ascends up into the common bile duct, creating the infection in a very, very serious situation because that can perforate. And the person can have acute peritonitis and an acute surgical abdomen and a very difficult recovery. All right, acute cholangitis results. So, acute cholangitis symptoms, Chocart's triad and Renald's pentad. The most serious one is the second one. Chocart's is pain, fever, and jaundice. The Renald's is those three: pain, fever, jaundice, and also mental status changes or confusion. Commonly termed as confusion, and also hypotension. So the person is having a volume change. Okay, they're becoming dehydrated, or it could be due to rupture, etc. Now, the problem with this is it's very, very serious, meaning if you have those five symptoms in this patient, the mortality rate can be as high as 50% mortality of the patient if they're presenting already at Raynaud's. Symptoms, obviously, right upper quadrant tenderness, guarding, hepatomegaly. We're going to also see, more than likely, almost always, white cell count elevation. And you're going to obtain ultrasound right upper quadrant, or a CT, or HIDA scan. You're going to do a MRCP, that's with the MRI machine, or an ERCP. You're going to go in there, you can take a look in that duct and find that stone. Okay, so you see it on ultrasound, you want to go get that stone. So the ERCP does both diagnosing, because there's the stone, and also primary treatment, which is remove the stone to get the flow of the bile out of the liver, etc. Start clearing the flow again, start the healing process before it becomes a fatal outcome. Choledocholithiasis, we can probably have possible, not necessarily emergent ERCP, but elective. But unfortunately, once you hit cholangitis, you have emergent ERCP surgery. It is right then, there, got to do it, got to get the stone out of there and re-establish the bile flow in the proper direction, and then the antibiotics on top of that. Left upper quadrant, we're going to shift to the left, still staying high, acute pancreatitis. Pathophysiology and morbidity, acute inflammation of the pancreas. Pretty straightforward. Mortality tends to be low, but if the presentation is more severe, your mortality rate does significantly increase. It can lead to necrotizing pancreatitis, 5 to 10% of the case, and potentially have a fatal outcome, unfortunately, for the patient, depending on how late they present to you. We're going to talk about that in just a second. Severe left upper quadrant pain. Here's the key word: radiating posteriorly, directly posteriorly to the left flank, 50% of the time. Person presents to you, they say, I think I got pancreatitis again. And you say, where are you feeling? They said, directly backwards to my spine. They don't have any urinary changes. They don't have any other changes. They just got the pain. They're more than likely it's another flare of their pancreatitis. This is just one of those folks look sick. They come in, they present ill. They are profoundly ill when they come in. They're in significant pain, diaphoretic, tachycardic, febrile. White cell count's going to probably be up. You're also going to have an amylase and lipase elevation. We'll get to that in a second on the confirmation of the diagnosis. But signs and symptoms, this is what you look for. Pull up their shirt, look at their belly, look at their flanks. If you have flank ecchymosis, that's great Turner sign. If you got periumbilical ecchymosis, that is a Cullen sign. If you have that, you better get your attending right away. Tell them, because there is a high fatality rate that goes up into that potential 50%, unfortunately, if it is presenting. This is a very serious presentation for acute pancreatitis when you have that ecchymotic lesions present on the abdomen. Studies, of course, amylase lipase. Amylase lipase, those are our two keys for pancreatitis. CT of the abdomen with IV contrast to confirm the inflammation in the pancreas. Diagnosis is made with the 3 A's, which is abdominal pain, amylase elevation, and CT of the abdomen. That confirms your presence of inflammation. Yes, I cheated a little bit, kind of bent it with the abdomen part for the third A, but just little quick things to help you guys remember when you end up with a board question on pancreatitis. There can be mild to moderate cases that are admitted and monitored. Unfortunately, severe cases, probably going to be an ICU admission. Persons with the Raynaud's pentad, definitely very serious, definitely ICU. Possible surgery for removal of pseudocyst, but we're going to hope that we can get enough antibiotics and cool the pancreas off and the person can recover. So pancreatitis is kind of low on the presentations, not that often, but it's very, very severe. Peptic ulcer disease, very, very common. Luckily, the opposite, not necessarily very fatal. Okay, so it's not as potentially life-threatening disorder. A lot of folks with peptic ulcer disease. Greatest thing about peptic ulcer disease is the fact that we discovered that H. pylori causes peptic ulcer disease the vast majority of the time. So the inflammation can be either an erosion of the mucosal lining, can either be in the stomach and or it could be in the duodenum. And duodenal ulcers, 50-70% of the time, H. pylori is found on the scope and confirmed by lab testing. And 30 to 50% of gastric ulcers have H. pylori. So what are we going to do? We're going to treat the H. pylori. That's the primary treatment. Antibiotic courses, H. pylori, we want to get rid of it. We treat the H. pylori recurrence rate 10%. You don't treat the H. pylori recurrence rate is 70%. So treat the H. pylori. Even if you're on the fence about it, you won't go wrong by treating the H. pylori with antibiotics, even if for some reason the results are kind of borderline. Just treat it, add that to the protocol so they won't have that 70% recurrence rate. Smoking, tell them to stop smoking. Otherwise, it's always good for healing, but it actually promotes ulcers, confirmed to promote ulcers. Age, unfortunately, as we get older, we're more prone to this. And then hospitalizations, people that are, in the hospital for multiple weeks, intubated and or just not getting up, and they're having a lot of reflux while lying supine. Symptoms: burning epigastric pain, coffee grind, emesis. That is due to the acute bleed. The blood then gets partially digested, and then when they vomit, it just looks like coffee grind and emesis bowl. There's no way around it. That's the perfect description of it. Hematoemesis. So let's say the ulcer just started bleeding and then they vomit strongly. You can get hematoemesis from esophageal varices, but also from the acute bleed in the stomach itself. You're also potentially going to find a positive cold card, Hemocold card as well. You're going to do basic studies, but the confirmatory study is, of course, is an H. pylori confirmation after endoscopy. Outpatient treatment is way more often than inpatient treatment. Our inpatient treatment is, of course, if there's a perforation and any infection potentially as well. Eradication of the H. pylori is the goal with the multiple different antibiotics courses, and that does a little bit depend on regionality. Always good to check with infectious disease to know, but luckily the antibiotics are pretty reasonable, pretty straightforward, and usually very affordable. All right, acute gastroenteritis. This is when our poor patient is sitting on the toilet, unfortunately, holding a trash can, vomiting at one end, and severe diarrhea out the other end. So this is nausea, vomiting, diarrhea across the board, your main three diagnostic symptoms when they come to you, plus the abdominal pain. The abdominal pain can be quite severe: cramping, twisting, crazy pain, or just kind of a low-grade persistent rumble. Inflammation is going to be from end to end, from the stomach to the small intestine to the large intestine, etc. It's usually almost always infectious. 1 out of 6 folks in the United States get food-borne illness each year. The main physical symptom, vital sign you're going to look for is orthostatic blood pressure, because we're going to see, is this person acutely dehydrated? What has been the amount of volume loss of fluid? And you're going to start that IV. You get the antiemetics going right away. We treat them with fluids, antiemetics. We want to stop the vomiting, but not necessarily the diarrhea. We want the body to wash out the pathogen. Unfortunately, sometimes we have to admit for either the severity of the dehydration or just cannot break and they cannot tolerate PO fluids. So they have to be able to convert from IV antiemetics to oral antiemetics to fluid toleration before they can actually discharge home. We don't want to send them home and have them come right back with intractable emesis again. Right lower quadrant appendicitis, top pregnancy, and ruptured ovarian cyst. I know the second two can certainly be on the left side. I put them on this side, on the right side, just for the sake of the lecture. Appendicitis, pathophysiology and morbidity. Acute inflammation of the vermiform appendix. Most common cause of acute abdominal pain needing surgery. Okay, so kind of say more often than not, you're going to have a surgical consult for acute appendicitis. You're always going to call, in a high percentage of the time, they're going for surgery very quickly. More common in adolescents and those in their 20s. Although I had a coworker who was 52 and ended up with appendicitis. So don't always expect things to be textbook perfect for you. Lifetime occurrence, about 5% of the US population have been documented to have appendicitis at some point. Classic presentation, right? Classic textbook presentation. Periumbilical pain, radiating to the right lower quadrant with lack of appetite, low-grade fever intermittently, and the pain is getting worse, getting worse, getting worse, getting worse. Classic. My friend who was 52, I just mentioned, he was a physical therapist, said he hurt in his right upper quadrant. That was the only thing. He only went to the ER because it wouldn't stop hurting. Ended up not with cholecystitis, but with appendicitis, and had surgery for 14 hours after onset of pain. He said the pain never relented, and that's why he went. Luckily, he did. Examination, pathognomonic, positive McBurney's point tenderness, McBurney's point tenderness. There you go. You got Murphy's in the right upper and right lower. You get McBurney's point. Rebound guarding more often. You can also have Rovsing's and obturator sign and vaginal bleeding. Vaginal bleeding occurs because the appendix that's inflamed lays on the posterior exterior lining, the outside of the uterus, irritates the uterus. The uterus starts having false sloughing of the endometrium and therefore false vaginal bleeding. So that's not just kind of, just the weird thing I'd put in there. It is actually a true phenomenon. Studies, CBC, CMP, etc. Is there a definitive lab for appendicitis? No. The good news is that almost all appendicitis is seen on CT of the abdomen and pelvis with and without IV contrast. So super. Our go-to standard, our standby imaging will find this absolutely. My friend had a CT, but they were looking for cholecystitis and they ended up confirming appendicitis. What are we gonna do? We're gonna MPO, we're gonna do the blood work, we're gonna prep them for surgery, we're gonna get them to surgery absolutely as quick as possible. They go right from the ER right to surgery. Ectopic pregnancy. The occurrence rate is actually fairly high. In my days, 11 years of emergency medicine, there is usually, unfortunately, several times per week, if not one per day, somebody would come in presenting with an ectopic pregnancy. So very, very common, and also can be extremely critical and life-threatening. So we do not mess around with ectopic pregnancies at all. Okay, we confirm it, or like, you're gonna have surgery. That's the bottom line. But it can occur within a 6 to 16 week gestational window. Bleeding can start slow and then suddenly get worse. It is not necessarily a always going to bleed this way versus that way. It can also be very rapid and to the point where the patient might exsanguinate. The intra-abdominal pain and perineal pain, the blood actually, because the patient's lying down trying to get comfortable, it can actually work its way to the right upper quadrant, left upper quadrant, create irritation and pain up there. And you're like, why in the world do they have that pain up there? That's why. I did have a case 25 years ago. Person knew they were pregnant. They had the pain. We confirmed very quickly the presence of the pregnancy, of the ectopic pregnancy, and that it had ruptured. She was having the upper quadrant pain, irritation. She was volume depleted. We were replacing fluids and we begged her to stay. She refused. She absolutely refused. She got into the ambulance, signed out from our facility, AMA, went 45 minutes up the road to the NICE hospital. Got a phone call 2 days later. The surgeon was very unhappy with me that we sent her. And when I explained that we begged her to stay and she refused, she said, okay, I understand. By the way, just to let you know, she bled so much that the coagulated blood was as large as a newborn child. So there's that much blood in her abdomen. She did almost sanguinate on the table, but luckily she survived and did well afterwards. But I told her we tried everything we could to get her to stay, and she would not. So please, you ever have a patient with ectopic pregnancy, please do anything and everything, and you tell them that story so they don't perish because of a decision they make because they don't necessarily like your hospital. All right. So, serum ACG, urine HCG, pelvic ultrasound will find and confirm your diagnosis. So it's a pretty quick study and non-invasive. And then again, you're prepping for surgery, absolutely 100%, and get them to surgery. Ruptured ovarian cyst is very common, but luckily not very critical. So it's going to happen very quickly. It's going to be very painful. It's going to happen suddenly. It's going to stop them in their tracks. Sometimes they literally, quote, I dropped to the floor due to the pain. It is almost like someone punching someone in the right lower, left lower quadrant. Very, very painful experience. And they'll get to you, will confirm that the corpus luteum had ruptured, and you check, and there'll be some bleeding at times, but not significant bleeding. Sometimes there's vaginal bleeding, sometimes not. And the cool thing is, usually, as they say with you in your office, in your clinical setting, in the ER, they actually slowly but surely do get better. They're able to be discharged home, follow up with OBGYN, and the diagnosis is confirmed with transvaginal ultrasound. After you have said, I believe this is what it is, then you get to confirm it with the ultrasound. Left lower quadrant, renal stone, diverticulitis, and our old friend UTI. Renal stones or renal calculi, they are going to be present and get stuck if they're 5 millimeters or bigger. There's your board question. Stones that are 5 millimeters or bigger are the ones that get stuck. They occur 12%, 10% for women, 12% for men. So really, statistically speaking, not much different. Okay, about equal across the board, roughly. Severe flank pain that radiates to the corresponding lower quadrants. So you'll have pain on the right flank going to the right lower quadrant and vice versa on the left. One of your tip-off things, always ask about flank pain if they come in and tell you they hurt just on the left, just on the right lower quadrants. The kidney stone flop is the patient is trying to get comfortable on the bed and they are flopping back, forth. They cannot get comfortable. If you walk in as a clinician, you're seeing that. They have, urinalysis with blood present urinalysis. They tell you, oh, I've had kidney stones in the past. Go ahead right away and get your definitive study, which is the spiral non-contrast abdominal CT. Do not put contrast in an enlarged kidney with dilated ureters, okay? The stone gets stuck, the ureters back up, the kidney enlarges, there's enough pressure and the stone drops down a little further into the ureter, and this pattern keeps repeating, so the person has wave-like pain. So it'll be good for a while, and then they'll start flopping back and forth. It doesn't get better until it drops into the bladder. So we confirm it with the abdominal CT. We provide them with ketorolac. It's a fantastic anti-inflammatory IV medicine for kidney stone pain. For some reason, it just works great. Antiemetic if they're vomiting, antibiotics if there's signs of infection in there as well, tamsulosin, fluids, and then follow up with urology for removal of the stone, and people get admitted with stones if they're obstructed and that stone is not moving. Usually we watch them through the ER process, get that stone into the bladder, and then we discharge them with a strainer to catch the stone to be analyzed, so we can say, hey, avoid these things so you don't get stones in the future. Diverticulitis, pathophysiology, ready? Inflammation of the large bowel at the distal end of the large bowel, ready? With or without diverticular infection, sorry. With or without diverticular infection. So diverticulitis is not necessarily infectious, okay? It's inflammatory, but not necessarily infectious. Severe bowel wall inflammation, you get perforation when the severe cases, you end up with peritonitis, fistulas, abscesses. It can be quite devastating for folks with very chronic diverticuli. Left lower quadrant hematochezia. Person says, they come in, hey, I'm kind of hurting a little bit, but I'm here because I stood up, looked at the bowl, and the entire bowl was full of blood. Okay, frank, red, bleeding, not just a scan them out with wiping, which is just a fissure. It's like, wow, I was surprised at what I saw. So definitely that's a very, very common history. They're going to give you your rectal examination. You're going to have blood on the glove. There's no reason to even do a hemocall because there it is. Abdominal and pelvic CT, ready? Abdominal and pelvic CT with IV contrast confirms your diagnosis. And then later on, after there's some bowel rest and there's dietary changes, antibiotics potentially from the ER setting, not always at the office setting, then you'll be able to go in with the scope, with obviously, bowel prep for one day, and take a look and see the severity and see whether there's any surgical need at all. You're referring to gastroenterology for that after they've been admitted. After they've been discharged home. You admit for core sepsis, fistulas, abscesses, perforation, any severe presentations. Good old UTI. So there's two types of UTIs. Most commonly, we just kind of think about cystitis, but pyelonephritis is actually upper tract, upper urinary tract infection is pyelonephritis. So upper tract is pyelonephritis, lower tract is cystitis. It's predominantly bladder. Yes, also urethritis and prostatitis. But vast majority of presenting cases are bladder and cystitis. And the main bacteria, of course, is our old friend E. coli again, 75 to 90% of the time. And unfortunately, the most likely person to come in with a cystitis presentation, unfortunately, is a female patient at 50-fold times more common from ages 20 to 50. Risk factors, of course, sexual activity, diaphragmatic use, spermicide, changes in sex partners, etc. For men, it's age, and age. Age and BPH, age and use of catheters, whether it's self-catheting, whether it's indwelling catheter, just unfortunately that sets more male patients up. All throughout the life, all age brackets, women more so than men, but men do catch up over time as the age is more likely a factor there. So cystitis symptoms, frequency, urgency, nocturia, dysuria, foul-smelling urine, still feels full afterwards or post-void fullness. Pyelonephritis, fever. Pyelonephritis, fever. There's your board question, okay? Fever sets pyelonephritis apart from cystitis almost all the time in almost all cases. Plus flank pain. They're going to have a fever. They're going to be sweating. They're going to be nauseous. I mean, they're going to appear toxic and ill on presentation. CVA tenderness present with the upper tract with pyelonephritis and suprapubic tenderness sometimes with cystitis. You're going to give a urinalysis, urine culture, non-contrast abdominal CT, so we can assess how the kidneys are looking if we have the high suspicion or confirmation of pyelonephritis versus just cystitis. Antibiotics kind of works for both, just a little more so than others. Cystitis, we can get away with anywhere between 3 and 5 days of treatment of nitrofurantoin, 100 milligram BID, TMP, SMX, double strength, 1 BID, that's just 3 days. Also, phosphosamine, 3 grams at one time, just a one-time dose if you want to utilize that. Pyelonephritis is going to be stronger antibiotics, more potent antibiotics, and also they're going to be for longer durations, ciprofloxacin, levofloxacin, and TMP-SMX, again, yes, double strength, but for 14 days, as well as fever control, fluids. So prevention and patient education is fluids. Again, unfortunately, female anatomy being what it is, you're predisposed more often than not to have this infection, and tell your patients, well, if you plan to participate in said activity, please drink a lot of fluids before and afterwards. And also if the session of that activity, trying to be polite here for sake of professional politeness, sexual activity when it's longer, and the old joke is it's not called honeymoon cystitis for nothing. So just tell your patients, you're going to have to make sure you drink a lot of fluids, and they're going to come back with you with cranberry juice. Cranberry juice, can I drink it? Does it work? Is it actually proven to work? And the answer is no. We actually do not have definitive, double-blind, placebo studies that confirm that cranberry juice actually prevents or stops early onset symptoms of a UTI. What it does do is it provides fluid. So if they want to drink fluids and they want to drink cranberry juice, fine. That encourages them to drink fluid, which that alone can just simply reduce the incidence of acute cystitis or urinary tract infection. All right, abdominal pain. Kids. How are kids different than us as adults? What do you need to know as the clinician? The round abdomen. So little ones up until about age 5, their bellies are round when they're standing, or you stand them up, and also when you lay down, that's perfectly normal. As they get older, when they stand up, they don't have massive musculature structure, so they do have a little bit of distension, but when you're lying down, it should flatten. So the age 5 to 10, 11, They have a little soft abdomen standing, but when they lay down, it's distended and hypertympanic. You need to be worrying about some pathology. Now, kids tend to be a little more hypertympanic because they're swallowing air. Good news about kids is the number one reason kids go to the emergency room is constipation and nausea, vomiting, diarrhea. And on examination, you're going to feel stool versus something scary called enterococcepsis. Okay. One little tip off here there at the bottom, abdominal series X-ray is actually preferred over the CT of the abdomen. Why? Well, how many rads, how many x-rays equivalent for one CT? And it's about 40. So the average CT is about 40 times the radiation in the area you're targeting. So it's like x-raying this little abdomen 40 times. Plain film x-rays do actually pretty good for kids. We can see things like this. This was actually my patient in the ER about 15 years ago, small bowel obstruction. He had a round belly standing, round belly lying. He wasn't crying. He was hypertympanic. Took the picture, small bowel obstructions right there. Don't have the CT. Young man was admitted for treatment, obviously. I think he was about 4, if I remember correctly. Thing just to when you're talking with kids, you can do an interview with a kid, with a child. There's something called toddlerese, which is basically child talk, and their parents are going to know what they're saying. My oldest said that a vacuum cleaner was a gup. His word for vacuum cleaner was gup. No one would have known that if we didn't tell them. So you may be looking and chatting and listening to the child say all kinds of things that makes no sense to you. You look at the parents and say, what in the world did they say? Because that child may give you that one little tidbit of the history that's going to help you make the final diagnosis. Now, this works for history gathering for any reason, but it's really super critical when you have the little guy with the scrapes and the breaks, and he says, "I also hit my stomach." What do you mean you hit your stomach? Well, I was riding my bicycle and I went over my handlebars, or I was on my skateboard, or something. So anytime your adolescent or child patient says there's any kind of trauma, make sure you always ask that abdominal question. Then you're going to do the exam. You're going to look for any kind of abrasion. And if so, your bells and whistles go off. You need to get your attending. You need to say, this is what happened. Please put your hands on the belly. See what they say. What should we do? The most aggressive treatment is they stay in the ER. They're observed, full blood work, IV access, and consideration at this point, yes, of a CT to make sure there is no liver or splenic rupture. Never send that child home who tells you I hit my stomach and there's any signs of trauma or tenderness, etc. Do the full absolute workup on that examination. Their bellies, they're going to be really anxious when you're coming at them. You need to help them relax, joke around. I'll tap the belly, and of course they're percussive, and I'll say, "Wow, did you swallow a drum?" By the way, that joke works every single time. They giggle, they relax. Again, your masses are more likely stool rather than enterococcepsis. When you get into the general rectal examination, get the permission. You see something unusual, stop, back up, get the attending, get them to cover it, because almost always in most states, it's going to be the attending that will be going to court if it comes to that, unfortunately, for that child. Also, remember, guys, the medical world for a child is super scary. Every time we see them, we smile, and we stick them with 1,000 needles. So they associate us, our white coat, or our scrubs with pain. So it's going to take a few minutes for you to kind of get them to relax. And also, there's this big doofy guy. That's me. I had my MA lay down, and I had he was like 5. He takes a picture of me. That's his perspective, right? Our elementary schools are all so much bigger till we grow up and go back. We're like, wow, okay, this is pretty small. So, case studies we got 2. We're gonna wrap up. This patient came to me 2012, I believe. She's a 24-year-old female, presents actually quite calmly. She said that she had right lower quadrant pain, sudden onset, 6 out of 10, and nausea, and essentially that was it. She was calm, she was collected, she's resting there. Right lower quadrant pain, sudden severe onset. She was sitting down watching TV. She did note that she had spotty bleeding and that she and her husband were trying to get pregnant again, and she was a week late. So we got a ruptured ovarian cyst versus ectopic pregnancy, right lower quadrant pain. We got to throw in, I guess, appendicitis in there. But they shouldn't have any kind of thing that says appendicitis going on right now. No significant family history, no past GI issues or past GYN issues. And she's just sitting there very relaxed and calm talking to me. Nothing in her history, past medical, past surgical, family history really helped out to indicate one way or the other. Nothing up here at the top of the vital signs helped. She was not orthostatic. She wasn't febrile. She was resting comfortably. But when I did the exam is the tip-off time. Did the exam, positive right lower quadrant, McMurray's point, tenderness, rebound guarding. She didn't have Rossing's or obturator sign. No signs of GI bleed. Vaginal examination had scant bleeding, but no pelvic tenderness. There was no thing that made me say, okay, this is, uterine or ovarian pain or an ectopic pregnancy. So I did some studies. She was not pregnant, confirmed both on the urinalysis and also the serum HCG. Unfortunately, this doesn't help. White cell count doesn't help at all, right? I don't see any signs of infection. I decided, why don't we go back to the basics, go chat with her again. She was again very calm. I re-examined her. She had pain. Again, right lower quadrant, over to McBurney's point. I'm like, okay, I'm thinking this is appendicitis. What am I going to do? Am I going to do a CT or an ultrasound? Well, we know she's not pregnant, so we can go ahead and proceed with a CT. What was the result of the CT? Appendicitis, boom, there it was. What did we do for her? We decided to call the surgeon and immediately rang the bells. Everybody comes running. We kept her NPO. Luckily, she already told her NPO. She had already been NPO for several hours. She was actually able to go right from our ER room right to the surgery suite downstairs and get her appendectomy right away. I mean, she was door to door from the ER door to the OR door in less than 2 hours. Everything lined up for this patient at that day. Luckily, the surgeon had just finished with one case and was able to go right to taking care of her. And this antibiotic was per her choice, her being the surgeon who did the appendectomy. Always ask your surgeons, what do you want me to order for antibiotics? Number two, this is one of these head scratcher cases that presented to me. And I kind of hinted at this case earlier in the lecture that sometimes your acute pain actually is technically chronic pain. So this patient came to me. She's 58 years old. She had a 2 to 3 month history, progressively worsening right suprapubic and left lower quadrant pain. She had bloating, distension, pain was increasing, got worse. And by the way, she had been to the other hospital in town just 2 days prior, had a full workup, was sent home with a phone number for a surgeon. Did they tell you what it was? I don't know what it was. No one really told me what it was. Unfortunately, that's where good patient education could come in this case. Her pain was 7 out of 10. She was steadily worsening. And she also had a cascade of other generalized symptoms of weakness, cold intolerance, fatigue, and intermittent fatigue. I'm like, well, I don't know what's going on there. She also noted there down at the end, otherwise healthy person and sexually active. However, she was postmenopausal. So sexually active, postmenopausal. Man, what is going on? Well, let's, examine the patient. Vital signs were not helpful, but the examination was very helpful. Felt firmness in the right and left lower quadrant. When I did the pelvic examination, I'm like, this is an enlarged uterus. And I palpated around and it palpated to about an 18-week gestational uterus. But there's no bleeding, no other signs of infection. And I didn't have my labs yet. So I'm like, I don't know. Maybe she's pregnant. Every woman that comes into the ER with a uterus and ovaries is pregnant until proven otherwise. So we're waiting for the labs. Labs finally come back. She's not pregnant. Great. Confirmed with urinalysis and serum analysis. But look at that RBC and H&H. Quite low. This patient is extremely anemic. So going through, we did provide her more pain medicine. My nurse thought she was kind of pain-seeking, but I didn't get that sense. I'm like, let's keep talking. I kept going to the room, talked to her a little more, kept building the rapport a little more. And I said, I'm going to order a CT, and it's going to be without any IV contrast. I'm like, okay, great, super. Order the CT. Well, there was numerous cuts that came across, and there's this cut. And I'm like, that looks like IV contrast. I went back into the room. I said, did you have IV contrast before? And she's like, well, no. You didn't drink, not IV contrast, PO contrast. She goes, no. I'm like, you didn't have any PO contrast? No. Okay. So I talked to the tech and I'm like, what would give me an image that looks like barium that's not barium? He says, barium is earth-based. Like, Now this is why she was admitted, and this is her 18-week gestational uterus due to a severe uterine fibroid. That uterine fibroid created her anemia. Her anemia triggered pica, and she started eating white clay. Now, white clay is produced in central Georgia. It's boxed on the shelves as a starch, but people will eat it like they eat paper. And she was eating white clay, and that gives you this looks like barium contrast, GI contrast, but it was not. So she was admitted and treated and did very well in the long run. So last thing I'm going to say here is there's a quote by an ER lecturer, Dr. David Lane. He says, there's only two things in medicine that we need to know well, which is, of course, the common and the dangerous. He said dangerous. I like critical. But hopefully you've seen and we discussed and you remember the disorders that were very, very common, that not critical, very, very common, and critical, and those that don't show up much, but when they do, you better jump right on it. Now, here is my email. And please, by all means, send me a question about this lecture if you like to. We don't have the ability with this setting to actually have questions, but I'm glad to answer them. And if you think I kind of made it up, I didn't. Okay, so these are my references, and I'm going to jump back here to that. And I thank you very much for your time, attention. Thank you for listening to and clicking on my lecture. I hope you guys have had a great conference, and maybe next year get a chance to see you all in person finally. All right. Thank you very much.